Okay, so thank you very much. And I'd like to thank all the speakers in this session. And at this point in time, I'd like to invite all of the faculty up to the front tables for a fairly brief question and answer period. And as well, Dr. McHardy is here somewhere. If we ask, okay, who is our visiting McLeod expert today? If he would also join us, please. You didn't have to shout your questions because I can't see them. Okay.
The rest are just calling.
Dan?
We're running a little late, so we have basically about 15 minutes to take questions, and I'd like to. We'll be able to take them in here in the conference room, and our staff is ready to come with a mic, and Ron Perlman is also watching, and he'll online to see if there's some questions. So they may accumulate, and maybe we can answer them later if they're not answered today. So let me have a hand up for any questions, please. And just state your name and who do you want to direct the question to?
Just a general one. It's Alec McKenzie from a pediatrician from Ottawa. Great talk on what we should do. A reductionist sort of health minister might say, in addition to all those great lifestyle things, shall we just put GLP-1 agonists in the water as well? And so where does that sort of pharmacology focus meet your world?
Thank you for that question. So, of course, in the interest of time, I couldn't delve too deeply into the fact that in addition to preventative strategies, we need to make sure that we provide that everyone who is eligible for effective treatments can get access to those treatments. And so right now, we're already facing a shortage of semaglutide, right? So we know that this is going to soon be unsustainable, and we're just not going to have enough healthcare and treatments for everyone unless we also think about preventive strategies. But yes, absolutely, we're all working hard to try and make sure that the healthcare system can be prepared for all the patients who need care and need treatments.
Can I add a comment to that, actually? This is Ron Kahn on the video. Can you hear me? Yeah, I just wanted to say that despite all the great data showing important weight loss with GLP-1 receptor agonists and their modified versions, it's important to keep in mind that this every therapy you have to also look at what are potential downsides. And while it has many upsides for weight loss and controlling diabetes and metabolic syndrome, a substantial fraction of the weight loss with GLP-1 agonist is lean body mass. In some studies, up to 40% of the weight loss is lean mass, which we would really like to preserve. So I do think that we need to not say that everything is solved, that there is still a need for continuing research, not just to develop the next GLP-1 polyagonist, but to also find better ways to induce a healthy metabolic state, including weight loss. That's just my opinion.
Thank you very much, Ron. There's a question here, Dr. Hawker.
Hi, thank you, Gillian Hawker, University of Toronto. On the same subject, it makes me very worried, actually, thinking about giving everybody a pill instead of being active. Sorry, because it's way easier to take a pill. But my question is really, we're learning an awful lot about satiety and what the central nervous system is doing in terms of our sense of satiety, our push to eat. Do we know anything about how the drugs that Dan and you were talking about might be positioned specifically at people or interact with people differently based on what's happening in the brain, basically?
So maybe I could address that at least in part, which is just to remind everyone that we know that millions of people with type 2 diabetes have successfully been treated with semaglutide, for example. The numbers of people who've been, and that's for over a decade now, the numbers of people with obesity who've been treated with these drugs is much smaller and for a much shorter period of time. So I think there are a lot of questions that still need to be resolved with respect to any potential long-term outcomes of using these drugs to treat people living with obesity.
Dr. McDonald. Oh,
Thank you. I'm Arthur McDonald from Queen's University. You mentioned the combined sensor and delivery system for type 1 diabetes. I've been hearing about this for quite a while. I happen to have a son with who's been very successfully treated for diabetes over his whole lifetime. He's 48 now. The question I have is there evidence that rapid response and adjustment of levels such as you could get from such advanced technology actually improves outcomes with respect to type 1 diabetes? And how available are these combined systems these days?
So that's a great question. I mean, I'll answer maybe your second question first. Being a physician who takes care of patients with type 1 diabetes, I know a little bit more about availability. There are still the approved systems. There are two out there right now that are available for people, but in terms of access, access to the for particularly the sensors, that's more limited. People have to have private insurance. But there are also a number of do-it-yourself looping sort of technologies out there that people are using that have been shown to be very effective, at least at auto-adjusting insulin. In terms of the evidence, I think we're still in early stages. I mean, I don't want to put Dr. Perkins on the spot, but he's the expert here. So I don't know if you would want to maybe tell us.
Yeah, sure. So essentially, there are all the systems on the market have randomized control trials that show benefits in blood sugar control measured by hemoglobin A1C. And that's our proxy for downstream things like complications. So they do, it's not extraordinary. It doesn't solve the problem of diabetes, but in our real world use, they tend to even show more amplified benefit. I have a feeling that in clinical practice, maybe we're better able to kind of select, or they self-select those who are most likely to benefit from them. So let's just put it this way. They make a lot of sense at face value. There is evidence from randomized clinical trials of better A1Cs. And in practice, like we do see that they help an awful lot of people. It's just right now, exactly as Lorraine says, the access isn't perfect. They're expensive.
thank you. There was a question over there. Yes. No? Okay.
I almost changed my mind. This is not clinical. When Dr. Drucker was speaking, I began to think, as he referred to drug companies, who's paying for this research? And then I hear later, of course, there's going to be great savings in terms of healthier patients. And it's just occurred to me that this group might have some people here who could briefly discuss, outline the economics of all this. Who's going to be a winner and who's going to be a loser, or does the money just keep turning around?
Who wants to answer that question? What do you think, Dr. Kahn?
Well, of course, the economics in the US are maybe a bit different than the economics in Toronto. I will comment by saying that over the last 5 to 10 years, Eli Lilly and Novo Nordisk have become the most highly capitalized pharmaceutical companies in the world, passing some of the other giants who mainly have been betting on cancer and other drugs. So this is a lucrative business. There's no doubt about it. And it doesn't mean it's not good business. It's just a lucrative business. I do think that for long-term therapy, we obviously have to put the cost into equation and find the best ways we can to, whether if we're going to do it pharmacologically, make drugs more affordable and safe as well as effective. So I think that has to be on everybody's long-term radar screen. But obviously preventing disease and preventing obesity, prevents a lot of disease, will be beneficial in many ways, as has already been pointed out. Also, treating diabetes directly is beneficial. SGLT2 inhibitors and other drugs are also quite good. So I do think that there's always the cost benefit part of the analysis, but I think that what we're now seeing, which we didn't see for some period of time, is a number of drugs and approaches that definitely have good long-term benefit. And we need to figure out now how to make them most cost effective.
Thank you, Dr. Kahn. There was a question here about a gentleman in the black sweater. Oh. Oh. So who else had a hand up?
Okay,
John?
Ron, online?
Yeah, there are a couple of questions. Most of them were actually questions or comments for Dr. Drucker, and they will be answered, I think, separately. And but there's one question that came from a trainee, it seems, and they're always interesting questions, and I think deserve an answer. If you were a PhD student or a postdoc just entering metabolism diabetes field, which project would you choose in 2023 and why? So let's see if anybody wants to tackle that.
Sure. I've trained a few people in my time. I think that the first answer really is the project that excites you the most is the one that you should take on, because you cannot be a successful graduate student unless you are passionately interested in what you are doing. And I think just considering that it is a process of training you to think, right? It's not a process that leads you to reward automatically, but it's a process that leads you on to the next steps in your life. And so your enthusiasm for that project is, I think, absolutely critical.
Dr. Kahn, do you have a response?
Yes. Well, I would agree first with what was already said, what was just said, but I would always say that if the best projects are the ones that ask the most important questions. And if you want to do something that's both interesting and will be appreciated ultimately in the field, is to try to think about how important is the question that you're asking. I would say that in all the areas of diabetes and metabolism, there's lots of challenges and important questions that remain. And I hope that people really recognize that. Even in the control of appetite and energy expenditure, yes, GLP-1 analogs cause people to lose weight, but they aren't the central hormones controlling appetite and energy expenditure. The central hormones are all hypothalamic hormones that we really have less control over, and we don't know how to modulate yet. The same is true in insulin resistance. We still don't know the fundamental cause of insulin resistance. And as I think was alluded to by the presentation by Lorraine, there's great opportunities in thinking about immunotherapy for type 1 and thinking about cell replacement therapy for type 2. And here it's not just the practical clinical application, it's really developing new approaches that will be safe in the long run to allow immunotherapy to prevent diabetes or to allow a long-term successful transplantation. So I think diabetes has got a lot of really challenges, important challenges, as does obesity, that remain. And hopefully, if you're interested, you can read a paper I wrote in the New England Journal titled How to Pick a Research Project. But picking a good mentor is the first part of it.
Okay, one final maybe question from the chat, which is general, and that is, what will be the role of insulin in future diabetes care?
Okay. Who wants to take that on? Who are the good doctors? I don't want to go back to you, Ron.
You keep picking on because I'm not there. That's it. But obviously for type 1 diabetes, insulin deficiency is the driver. And so we have to figure that we're going to definitely need insulin therapy unless we develop some form of either effective immunomodulation to block the development of type 1 diabetes or effective cell replacement therapy to treat it. And so I think insulins continue to be worked on to develop what are called smarter insulins that could self-adjust to changes in blood glucose, insulins that might have special properties that allow them to be more active under certain circumstances, like on the liver or the muscle or the fat. So insulin continues to be really an important a part of this whole thing. And there's still a number of companies working on trying to get orally available delivery methods for insulin, which would obviously eliminate some of the other concerns. But these combination pump sensors are really terrific for the people that are able to use them. So I think insulin is not going away, at least not over the next, I don't think it's going to go away for the next 10 or 15 years. Maybe in the next 50 years, it'll go away, but I don't think so in the short term.
Thank you, Dr. Kahn, for your participation. I'm going to take a final question from Ivan Semeniuk. And then we're running a little late, and I might say that in an hour or so, about 100 people are gathered to really celebrate at a dinner that kind of mimics the dinner that was held 100 years ago to honor the Nobel Prize to Banting and McLeod. I have a feeling that the equanimity will be somewhat happier and that there will be less controversy. And having put behind the complications and the human frailties of the day behind us. But let me take a question from Ivan Semeniuk from the Globe and Mail.
Thank you very much, John, and thanks for making some time. I would actually like to take it back to the history, and maybe that's a good way to wrap up today. Of course, this is a speculative question or kind of a counterfactual, but I'm wondering, from the perspective of the Nobel Prize and the events that followed, how the rancor or the rivalry or the controversy might have harmed the university and perhaps even the broader Canadian research landscape. I'd love to know from some of the panelists if they think there was harm, and if so, or whether there was or not, is there a different kind of legacy they might imagine had that rancor not been there?
Jim, I'm going to ask you.
So I would certainly imagine that the university benefited much more from the discovery of insulin than any kind of harm that was generated. These are all interesting people that got to where they were at because of personality quirks. And I think you just kind of have to accept each one was a key part of the puzzle, or solving the puzzle, but each one's different and each one's going to have different perspectives. And so I think undoubtedly the university benefited much more than any of the rancor actually hurt the university.
Any other comments? Ken, do you have a comment?
Yeah, I could maybe just add to those impressions that the investment after the discovery, the tangible investment, was made in Banting and didn't yield very much. McLeod, who had done great work in Cleveland and in Toronto, went on to do great work, but not in Canada, not associated with Toronto. Collip, who largely kept out of the argument, did the best work, I guess, for medical research in Canada. And Best also had a pretty impressive career as a physiologist, notwithstanding Michael Bliss's rewriting history paper, but Best and Collip certainly achieved in Canada. And they were the two people, I guess, least involved in the overt fisticuffs or whatever in the years after the discovery of insulin.
Well, I just want to say we've had a terrific afternoon, and it really underlines the fact that carrying out a celebration for something as important as that prize, Nobel Prize, given 100 years ago for the discovery of insulin, and honoring Banting and McLeod, highly deserving of a celebration and a serious look back as to what happened and where we've gone since, which is also so well described by the speakers. So I thank my co-chair, Pat Brubaker. I thank Lorraine Lipscombe for showing us a bit of the future. It's been so great to have Professor Erling Norrby with us, who had all the Nobel insights and still follows us very acutely. For Jim Wright, who was very been very direct in finding what really happened, being provocative, but that's what's needed. And Ron Kahn, so good that you stayed with us all afternoon. We wish you good health and say happy birthday to your wife, Susie. Her birthday
Okay,
is today.
thanks.
And I
Everybody
want to
should know
thank
I am fine. I just couldn't make the trip for a little problem. It's
I
okay.
realize that. Give my best to Susie.
All right.
And thank all of you for coming and those online. Very much appreciated. And we'll celebrate some more at another in the evening in about an hour. Thank you all.